Hello, my name is Debbie Leone and I am the Information Services Coordinator or Manager for the Epilepsy Foundation of Minnesota. I am going to see if I can share my screen here real quick before we can get started. And let's see. There we go. Okay. So I want to welcome everybody tonight to the Epilepsy Foundation of Minnesota's Wellness Wednesday webinar, Navigating Your Epilepsy Diagnosis. We are really excited tonight to have two very knowledgeable epileptologists joining us as our speakers, and I will be introducing them in just a moment. But first, I want to start with a few housekeeping items. The webinar will last for an hour and 15 minutes. And in order to have the best webinar experience, we do ask that you close down any windows on your devices that might use a lot of bandwidth, things like music or streaming services. We will provide a certificate of attendance for you, which will be sent out via email within 3 business days after this webinar. The webinar is being recorded, and a link to request that recording will be posted on the EFMN website for future viewing. And you will notice that we have closed captioning enabled. If you don't want to see those captions, you can click on the CC icon at the bottom of your screen, where you will be able to choose to hide the subtitles. I want to let you know that while the Epilepsy Foundation of Minnesota is hosting this webinar, all content and discussion points are led and delivered by our speakers from Minnesota Epilepsy Group and Sanford Health. The information we're sharing is to inform you of various aspects of navigating an epilepsy diagnosis. However, all potential treatment options should always be discussed directly with your own medical provider. We do encourage you to ask questions throughout the webinar, and you can do that by clicking on the Q&A icon that should be located at the bottom center of your screen. That will then bring up a box where you can type your questions and then hit send. We're going to hold the questions until the end of the webinar so that our speakers can answer them all together, but we encourage you to ask those questions in that Q&A box as they occur to you throughout the webinar. Our speakers will not be able to offer medical opinions about your individual diagnosis and treatment. So for that reason, and to respect everyone's privacy, we ask that you please keep your questions general and not specific to your own or a loved one's epilepsy. You can also use that Q&A box to let us know about any kind of technical difficulties that you might be experiencing. Our executive assistant, Mary Mavison, is here with us off camera, and she can help with those types of questions if you just type them into that Q&A box. And to avoid any confusion, the chat feature has been disabled. And in case you're wondering, we cannot see any of the attendees or hear you. Your microphones and your cameras have all been disabled. You can just hear and see us. So let's talk about what our objectives are for this webinar tonight. The first is to understand how an epilepsy diagnosis is determined, to identify the crucial first steps following diagnosis to establish a treatment plan and to work with your doctor towards seizure management, to explore the activities and aspects of life that may be impacted by an epilepsy diagnosis for both adults and children, and to recognize the importance of social and emotional support and strategies for finding it. So I want to move on now and introduce our presenters who we're so excited to have with us tonight. First is Dr. Brian Mendez. He is a pediatric epileptologist at Minnesota Epilepsy Group. Dr. Mendez completed his undergraduate at University of Illinois at Urbana-Champaign before attending medical school at University of Illinois Chicago. He then completed his residency at Cardinal Glennon Children's Hospital and his fellowship at Children's Hospital Colorado. Dr. Mendez's areas of expertise and interest include new onset epilepsy, epilepsy in adolescents, dissociative/psychogenic non-epileptic seizures, and quantitative EEG. Outside of medicine, he enjoys trail running, board and tabletop games, science fiction novels and films, and photography. Dr. Mendez has his own childhood history with seizures, which he will share during his presentation, and he finds working with pediatric patients very rewarding. Our second speaker is Dr. Alexandra Sequeira. Originally from Vancouver, Canada, Dr. Sequeira began her path towards neurology studying psychology at McGill University in Montreal, Canada. She next pursued a Master's of Clinical Neuroscience at University College of London, Queen Square in London, England, where she received a Master's with distinction. She then began her medical studies at St. George's University in Grenada, West Indies, which led her to New York City to complete her clinical rotations. She completed her neurology residency at New York University and then went uptown to New York Presbyterian Weill Cornell Medical College and Memorial Sloan Kettering to complete her fellowship in clinical neurophysiology epilepsy track. From there, she moved to Fargo, North Dakota with her husband and children, where she joined Sanford Neurology. She has an active adult outpatient epilepsy practice. She participates in the epilepsy monitoring unit, conducts medical student professor rounds, and is also a core faculty member of the neurology residency program. Additionally, she serves on the professional advisory board at the Epilepsy Foundation of Minnesota, the American Epilepsy Society Early Career Committee, and she's been selected to the American Academy of Neurology Emerging Leaders program. So you can see why we're very excited to have both of these speakers here with us tonight. We're thrilled that you're here, and I will now turn things over to Dr. Mendez.
Thank you very much, Debbie. That was a wonderful introduction. I'm going to quickly request screen co. I think I got it. I was asked to kind of start the initial portion of this lecture talking about the history of epilepsy and what epilepsy is and what the diagnosis is. But I did want to start with kind of a quick history of someone who had epilepsy. And hold on, there we go. And that person is me. So this is a snapshot of Dr. Mendez circa 1999, just before his first seizure. And if you kind of plot out what my seizure diagnosis, how seizures affected my life. I had my first seizure around 2000 in fifth grade math class. Yes, I do remember which class it was in. And then a second seizure in sixth grade shop class. That was when I was put on a medicine, and then I was able to get off of that medicine in 2004. And then I got my license in 2005. And, really, if we think about, if you kind of view this from a doctor's perspective in terms of this person's history of epilepsy and whatnot, you think that that's a pretty small portion of their life related to epilepsy. Flash forward all these years later, when I graduated from medical school and became Dr. Mendez, this portion represents a pretty small aspect of my whole life. And as speaking to a group of people that had epilepsy, I don't need to tell you guys that there's a lot more to that, because there's a lot of things that if you were to kind of look through this in a patient chart, that they don't necessarily bring up. We're talking about lots of missed classes because of seizure auras and potentially could be related to anxieties from the seizures. We're talking about weight gain from the Depakote that I was using. We talk about poor grades in seventh grade and a little bit after. We're talking about social issues from, just being an awkward kid just at baseline, and then adding seizures on top of that didn't really help things. Also talking about, sleep anxiety issues, being told that, if you don't get exactly 8 hours of sleep, you're going to be having a seizure. That led an already anxious kid to having a lot of issues with that as well. And so there's a lot of stuff that goes into this that doesn't necessarily, make its way into if you were just kind of looking at it objectively. And where a lot of people think that this is the stuff that led to me being Dr. Mendez. If I'm being honest with myself, this is the stuff that put the biggest, that was the biggest influence. So hopefully that gives you a little bit of backstory in terms of where I'm coming to from a personal experience with epilepsy. And before I go into the workup, I'll do kind of a quick example of what seizures, what are seizures and what is epilepsy. This will be a big shock to everyone, but this is a brain, and brains are composed of all these little cells called neurons. And they talk to each other by sending little electrical signals to each other. And that lets us do all the normal parts of being, of just living. So it allows us to talk, it allows us to do fine motor skills, and it allows us to think. It allows us to be humans. And this is when it's doing everything appropriately. When it's not doing appropriately, you get unorganized and chaotic or rhythmic activity, and that's resulting in a seizure. The important thing to realize as we get into seizures versus epilepsy is to know that seizures are a symptom. Okay, Okay, so it's like a cough or a sore throat or a fever. And just as important as, there's many different reasons why you can have a cough or many different reasons why you can have a sore throat, and seizures are the same thing. Epilepsy is just a disorder for many different reasons to which you are more susceptible to having seizures. And that could be for many, many reasons. So it could be due to a stroke or a brain tumor, or a traumatic injury. If you have a head injury, there can have seizures secondary to that. Or it can be like me. It was something in my genes that made I was destined to seizures. I was lucky and I was able to get off of medicines for a while, but there are many different causes. And in the same way that we need to know what causes our epilepsy or our coughs, colds, because they're treated differently, identifying the cause is just as important. So let's talk about and that's because we have the what, seizures, and we need to know the why. So before we go into the specific workup, let's talk about the levels of care when you're dealing with epilepsy. And the first is actually not necessarily a neurologist, it's your primary doctor. This is usually your first point of contact for pretty much all of your healthcare. Doesn't usually manage epilepsy. There are some exceptions to that, but by and large, they're not the ones that are taking the reins of managing your epilepsy, but they are very key in managing your overall health. So it's important that when you talk with your seizure doctors, that you're always keeping your primary doctor in the loop, because they're managing you as a whole picture. So it's always important to keep them involved. The next tier down from that is the neurologist. And this is typically the first brain doctor that you're going to see. They handle most kinds of epilepsy, and there are many kinds of neurologists that handle all kinds of epilepsy. But they also have a more of a wide range of treatments that they follow. They handle tics, they handle headaches, they handle if you have stroke symptoms of nerve pain, there can be handling of many, many different things. But they aren't as often as specialized as a seizure specialist. And that's where you get to tier 3, which are the epilepsy doctors. And this may overlap with tier 1 or tier 2 in that you may be seeing them as a after a first seizure. I have seen many first-time seizure patients as well. But the distinction is that they have extra training that helps them handle rare epilepsies or very difficult epilepsies, epilepsy surgeries. And they often, but not always, are limited to epilepsy. So sometimes you will be seeing a neurologist and then also seeing an epilepsy doctor. And then last but not least is kind of a quaternary care center. So these are the national centers and specialist groups that are specifically tailored to very, very, very specific epilepsies. But the important other thing to remember is that these aren't necessarily one, progressing directly up the chain. You may go from the primary doctor to the neurologist, who then may refer you to a seizure specialist and so forth. You may start at one and then go back to the other. Really, the important thing to keep in mind is this is a team, right? So you want to make sure that it's all these different components of your care are keeping track of where your seizure diagnosis is, and that everyone's in the loop, because everyone is a key component of your epilepsy care. So let's talk about an epilepsy workup. And it's really split into, I've arbitrarily split these into 3 big groups. So looking for a cause, comorbid conditions, and then surveillance. And we'll go though into a little bit more detail, but I won't take up too much of your guys' time. But we'll start with the basics. And this is the one that everyone has experience with. It's the EEG, or the electroencephalogram. And that's that big, the hat with the sticky stuff that's measuring your brain waves. And that's usually how we determine whether or not you have epilepsy. And to not go into a super crash course in terms of you starting your own fellowship, but we can't look at each individual neuron that's firing and seeing what that is. It's sort of like, hopefully that's a little bit better. It's sort of like if you were to imagine the Viking Stadium, right? It's like listening to a single voice amongst the whole stadium, right? You can't really do it unless you're right next to someone, but you can hear a general kind of murmur or a pattern. And that's sort of what I think about when I'm looking at an EEG. It's not looking at each one of those cells individually, but it's looking at the general pattern. Now, sometimes when you sing the national anthem, you can see a general pattern emerge. You can hear people roughly saying the national anthem, and that's sort of what I look for as a seizure doctor. I'm noticing things like a posterior dominant rhythm. These are hallmarks that we look for. Now, let's say it's a big complicated game, right? Let's say it's going to be between like Green Bay and the Vikings. things. And there's Vikings fans and there's Packers fans, and they're in different sizes, and it's getting kind of hairy. And that may cause asymmetry that we're listening to, and that, or what we're looking at. And that's sort of like if you think about focal slowing or focal discharges, those are things that I'm looking for. Sometimes someone scores a touchdown, everyone's cheering, everyone's really excited. That's kind of what I think about when I think about a seizure. So this is a big broad strokes in terms of what an EEG is, but hopefully by using this analogy, you get a little bit of an idea rather than this just magical device that they put on your head and that's reaching for a diagnosis after that. It's not the only thing that we use for a workup. There's other things like imaging that helps find other information about causes. So this is an MRI of a person that has tuberous sclerosis, and this is a tumor that they're seeing in their brain. There's genetic testing that's offered. This is often more in the pediatric rather than the adult population, but it's not always that case. And it can look for specific genes that could be related to your epilepsy. Once we have an idea about looking for a cause, the next is looking about comorbid conditions. So here's, again, a patient that has tuberous sclerosis. And we know that patients with TS have other conditions that we need to screen for. So we need to sometimes look at the kidneys, looking at the heart to see if there's additional pathology. There's other conditions that make you predisposed to eye findings. So maybe you're going to be looking at other features. And those are often specific to what kind of epilepsy diagnosis that you have. Additionally, we know that there are common conditions that are associated with most epilepsies. And these are things like depression, anxiety, ADHD, whether you have the H or not, inattentiveness, specific learning issues. And these tend to go along with a diagnosis of epilepsy for many different causes. And it's fairly common to the point of where in Minnesota Epilepsy Group, we have things like the No Clinic and an adult version thereof, where we have psychologists and neuropsychologists available. This is by no means something that's required, and it's not something that all of my patients will go see. But what I would take home from you is that to be aware if you're struggling with anxiety, if you're struggling with issues related to school, to bring this up with a neurologist so that they can potentially look into how they can help you, because this is often a common comorbidity with epilepsy. The last step in terms of the workup is what I call surveillance. And this is largely to do with the medications that you're taking. So certain medicines will affect your liver enzymes. They can affect your blood levels of red blood cells, white blood cells, all sorts of blood cells, and they can affect your acid-base balance. And these are things that will likely be a reality for a large portion of your epilepsy story, just to make sure that the medicines that we're treating aren't causing undue, aren't worse than what we're trying to treat. And I'm kind of blasting through a lot of this and going a little bit quickly, but I'm happy to answer more questions about this afterwards. I believe the next step, is going to be Dr. Sakira, and I'm going to give up control, and that's back to Debbie, and on to Dr. Sakira.
Great. Thank you very much, Dr. Mendez, for sharing your story. So we're going to move along and talk about how epilepsy is treated. So, the first step is you have an episode, there's concern that it could potentially be a seizure, you seek medical attention, and, the diagnosis of epilepsy is entertained or formally diagnosed. And so then the next point in the discussion is, what is the best medication for a particular individual? And I want to say one thing that's really important is that there's no one size fits all. Everyone is so different, and we think about so many different factors as epileptologists when selecting a medication. So part of it is, what Dr. Mendez mentioned already. So what did your EEG show? What does your MRI show? What are your comorbidities? What potentially is your genetic, what have your genetic results revealed, et cetera. So we're thinking about so many different things when selecting a medication. And I also think about it as it's an evolving process. So, we're starting out, we're selecting the initial medication, but there's loads of room for change. So I do think it's really important to keep that honest and open discussion with your healthcare team and know that you're not stuck on a particular medication. So medications are the primary way in which seizures are controlled, and our first line therapy. And different meds work for different types of epilepsy and different types of seizures. So one initial question we're always asking ourselves is, do you have focal epilepsy, where one part of the brain is involved at seizure onset, or generalized epilepsy, where both sides of the brain, both hemispheres, are involved at seizure onset. And there are certain medications that are best for only focal onset seizures and can actually make generalized seizures worse. So we're always thinking about that. And that is, again, a combination of what does the seizure look like, if there's video footage available, et cetera. What does it sound like based on the detailed history provided by the individual with epilepsy, and collateral information as much as we can get. What does the EEG show? What does the MRI show, et cetera? So medications control seizures for the majority of individuals with epilepsy. So most individuals with epilepsy can have seizure control with medications. And just remember, never abruptly stop or change medications without involving your healthcare provider. If you're not tolerating it, certainly let them know. If it's more acute, there's concern for allergic reaction, which we'll get into. Definitely don't wait for their office to open, go straight to the emergency room, but don't stop the medication abruptly in general. Next slide. So medication effectiveness, 47% of patients find control with their first medication, 13% with their second medication, but only 1% find control with their third medication. And so what's really important here is to initiate anti-seizure medication and look out for any potential ongoing evidence of seizure of seizures. And sometimes if an individual is not responding to medications, you're going to start thinking about other therapeutic options. And this is where, as Dr. Mendez outlined, primary care, emergency room, maybe you're seen initially, and then to neurology, then maybe an epileptologist like myself working at Sanford and Fargo, but I refer out to Minnesota Epilepsy Group, MinSEP, Mayo Clinic, as well, to a tertiary epilepsy center sometimes when someone's not responding to medications. Next slide. So choosing a medication, there are loads of medications. This is one of the really fun things about seizures and treating seizures. And again, when choosing, we're considering the seizure type, epilepsy syndrome, the potential side effects, co-occurring medical, neurological, psychiatric disorders. So what Dr. Mendez was mentioning already. So we're always thinking about the comorbidities and whether or not we can target another potential underlying health condition with one medication. So for example, if someone's having a lot of migraines, we're going to be thinking about a medication that also can help with migraines. Or if someone's having a lot of anxiety or depression, there are some medications that are have a higher association with exacerbation of these underlying psychiatric conditions. So we're always thinking about this. And we're always looking at the medication list because we're trying to avoid drug interactions, or at least be aware of them. And so how the specific medications are metabolized, and just make sure, because that can affect the therapeutic sort of levels in the blood and that type of stuff. Of course, any female of childbearing age, there are certain medications that we do our best to avoid because of the potential for harm to the fetus, and any potential impact on pregnancy, breastfeeding as well. So these are discussions that we're having, very open, honest, evolving, and really proactive. So not waiting. We're kind of engaging these conversations early on. The other thing is individuals that are older are known to metabolize medications differently, and they may be more susceptible to cardiac complications of some anti-seizure medications or electrolyte imbalances. So for example, low sodium. So again, we're thinking about all these things. And, if ever you pick up your pill at the pharmacy and it's looking different, you're like not sure if it's the exact same one, you can always let your healthcare provider know, and so that we're aware, and we may potentially have some specific advice depending on the situation. Next slide. So the goal in treating seizures and epilepsy is seizure freedom without side effects. In fact, even potentially, if you're able to target one of those comorbidities, an improvement in quality of life. Now, this is not always attainable, but this is always what we're striving for. If someone continues to have seizures on one medication, which we also refer to as monotherapy, a second medication might be added. Again, when we're adding medications, we're thinking about how to optimize seizure control, but also side effect profile. So for example, we might be selecting a medication that has a different mechanism of action. So it works different, it works on different receptors in the brain. Again, trying to avoid additive side effects, again, if possible. So it's really important to take time and to go through things in detail, and to be honest and open with your provider and healthcare team about how the medication's working and any potential side effects, and whether or not they're tolerable, intolerable, etc. They may be evolving, they may get worse all of a sudden, and that might actually be an indication that there has been another medication added or some sort of change in metabolism. So it's really important that everyone's on the same page, and that this honest, open conversation is happening. So next slide. So definitely ask questions before starting a new medication. For example, how does this medication work, and is it different than other medications that I've been on before? And why are you selecting this? Why do you think it's a good medication for me, right? It's a relationship that individuals are initiating with this medication. And so it's really important to feel comfortable. What is the research behind this medication? What is the likelihood that my seizures are going to get better? Does the way the seizure medication work mean that it may work better when given with some medications than with others? So some medications alter the metabolism of others, kind of what I was mentioning before, and can sort of affect the efficacy of certain medications. Also, what are the side effects of the new medication? What can you expect when it's added to the medications you're already taking? And, with side effects, what is the most common side effect? What is the most serious side effect? What should I be looking for? What do I do if I'm concerned about a side effect and I can't get in touch with you? These types of questions should be addressed. And then, whether or not this new medication might interact with other medications you take for other reasons. Next slide. So side effects. So there's loads of different side effects for every medication that's out there. And that's not limited to seizure medications. And side effects can occur at any time. So often they happen. Oh, am I cutting in and out? Sorry, my kids are eating dinner. Are you guys able to hear me? Dr. Mendez, I see you. Okay. I will try.
Dr. Sakir, if you're looking at those question and answer, I think that was about my audio going forward. If that's what you're looking for, I'm hearing you just fine.
Okay. And is there too much noise in the background? Okay. And so side effects can occur at any time. So this is really important. Often they occur at initiation of the medication or with dose escalation. So if you're increasing the dose, the side effects can appear, but they can occur at any time. So it's very important to be aware, to communicate them, and make sure you're feeling heard. Adjusting the dose, or the formulation, whether or not it's extended release, immediate release, might help. So there are different options potentially depending on the medication. And oftentimes medications are tolerated. Some side effects can be tiredness, cognitive, slowing, sedation, feeling nauseous, dizzy, as I mentioned, fatigue and mood changes. Next slide. So signs of rare drug reaction. So if you develop a rash, fever, sore places in the mouth, bruising easily, weakness, a loss of appetite, or a paradoxical increase in seizures, meaning all of a sudden your seizures are increasing, those are signs of serious drug reaction. And you should discuss with your healthcare provider recommendations for that. So what to know? So make sure that the doctor and the pharmacist know about any other medications. Take medications at the same time each day. So I encourage all of my patients to use a cell phone alarm and a pill box. Not doubling up necessarily on medication after, if you're concerned that a seizure is going to occur, but to discuss a seizure rescue and action plan, which we'll talk about a little bit later. And again, medication non-adherence or not taking medications consistently is the number one reason to have breakthrough seizures. So just continuing to be consistent with medications. And it's really important, and I inform all of my patients to talk to the prescriber of any new medication, the pharmacist, and potentially send me a message when new medications are added to make sure there's no interaction, or whether or not the new medication can lower the seizure threshold, meaning it can make seizures more likely to occur. Next slide. So some ways to improve your medication adherence. And again, there's several reasons. Having side effects, forgetting to take it to school, then you're at school and you don't have your medications, or going on a weekend trip or something like that. Not being able to get to the pharmacy because of a snowstorm, or because you can't drive, or financial. There's several different reasons, and this should also be addressed with the healthcare team. Side effects, and as I mentioned, can be addressed based on modifying the dose potentially, or changing medication. The other thing would be potentially just saying, if it's really hard to take medications twice a day, which it is, and it's known that the more medications one takes and the more frequent, the chance of missing medications becomes higher. There are a couple of anti-seizure medications that have extended release formulations, and so that might be an option. And then, having a seizure diary with reminder features, setting an alarm on your phone, using those phone apps, and having pill boxes, and maybe a pill box at home and in your backpack or your weekend bag, etc. Next slide. Rescue medications. So talking to your healthcare team about having a good seizure action plan is really important. So what do I do if I have a seizure? And what are things I should be, really worried about? When are times that I should be calling 911? And the Epilepsy Foundation has a great seizure action plan form, which is available online, which is really great to use. But in general, rescue medications are used for seizure clusters. So when seizures are just occurring at a higher frequency, and when there's potentially not a return to neurological baseline, when seizures become more frequent, longer in duration, or are more severe. And they're taken as needed. So they're not a maintenance medication you're taking every day. It's a rescue medication as needed in this emergency. There are different forms and delivery methods. So there's rectal gels, buccal liquids, and films and nasal sprays. So the newest medications are the intranasal, for example, midazolam and diazepam. Coming up with that seizure rescue plan, and also looping in your community, and we'll talk a little bit about that in a couple of minutes, in order for everyone to be aware of what the plan is and how to deliver these medications. Next slide. So ideal rescue medication is easy to use, works very quickly, safe with little to no side effects, and is in the best form to meet a particular individual's needs, and is efficacious, works well. Next slide. So other treatment options. So when seizures can't be controlled through meds, it may be time to consider other options. So some potential options would be surgery, implanted devices such as the vagal nerve stimulator, or responsive neurostimulation, VNS, RNS, diet, so the ketogenic diet, or a modified variation, and potentially cannabidiol or Epidiolex or another medication. Next slide. So seizure triggers. So everyone has their own, specific seizure trigger. So it could be a situation, for example, bright flashing lights that tend to result in having a seizure. The most commonly reported seizure triggers are missing medications or taking medications late. Stress, so significant increase in life stressors, emotional stress, anxiety, sleep deprivation. There can be influences of the hormonal cycle and the menstrual cycle and hormonal changes that can definitely influence seizure frequency, and that's something that should be addressed with your provider. Alcohol and drugs can definitely alter the seizure threshold. Drug interaction. So as I mentioned, some medications are known to make seizures more likely. And it's really important to be aware when starting a medication. Overheating, dehydration, decreased oral intake, missing meals, and then as mentioned, the photosensitivity can be a trigger. Next slide. So creating that seizure action plan, we sort of talked about this a little bit already. So just coming up with your own individual unique action plan, how to respond, when to call 911, and you can use that Epilepsy Foundation template or another one, and make sure that if you feel comfortable looping in your community, sharing it with individuals that may see a seizure and be around you in the time of having a seizure. Next slide. Epilepsy and employment. So, as we've heard, individuals who have a history of epilepsy or who have epilepsy are able to do many different types of jobs. There are a couple of jobs that you cannot do. Depending on the frequency or severity of the seizures, epilepsy can cause safety concerns or difficulty with employment. Medication side effects can also potentially cause challenges at work. The logistics of not being able to drive in the event of a seizure can affect someone's ability to get to and from work. And severe uncontrolled seizures or significant comorbidities can also affect an individual's ability to work. But things evolve, things change, and I think, everyone has a very different and unique experience. Next slide. So under the American with Disability Act, employers cannot discriminate against an employee with epilepsy. you don't have to tell your employer that you have epilepsy. It's up to you and your comfort level. And so if you do feel comfortable, it might be helpful in the, to make sure that you're optimizing your work conditions for seizure safety. And to make sure, again, with those seizure action plans, if I do have a seizure, this is what you should do. And employers aren't able to tell your coworkers about your diagnosis. Next slide. So epilepsy and driving. So every state has their own driving law, and the Epilepsy Foundation also on the website, you can plug in the state and it will pull up what the driving law is. So it's important to stay up to date and familiarize yourself with your local state driving law and comply with the DMV regulations. So individuals who carry a diagnosis of epilepsy are able to drive if they're not having seizures, which would cause safety concerns when driving. So things like losing consciousness, losing awareness, losing motor control. In Minnesota, you need to be seizure free for 3 months to be able to drive. And the DMVs are, well aware and are able to also provide guidance in this respect. In Minnesota, it's a self-reporting state, so seizures need to be reported by the individual within 30 days of a seizure. And then you can work together with your healthcare provider, depending on the timeline of seizure freedom, and can fill out specific paperwork in order to reinstate your driver's license. Again, if you moved from another state, or if you're living in Fargo, or, there's all these different state laws. So every state is different, but that is the Minnesota state law. Next slide.
I think that's mine, my cue, Dr. Sakira. So I just got a couple of notes in the messages that the audio was cutting out when I was here. So hopefully I've moved on to this nice ugly headset, and hopefully it's going to be a little bit more uniform. But if it's still an issue, make sure to let us know. Okay. So last, but now we'll move on to kind of going back onto the pediatric side of things, and pediatric into adulthood. We're talking about college age, high school age as well. What do schools need to know? Now, speaking in very general terms, schools want to know what kind of seizures does the patient have? What do they look like? How often are they? And what you can do about them. And most of this, I think we're 3 for 3 now in terms of mentioning a seizure action plan. But the my animation might not have gone through. Give me one moment. There we go. Seizure action plan covers this. This is one that we have at Minnesota Epilepsy Group. But again, I would envision that the Epilepsy Foundation also has a great example of this as well. Less generally, it depends on the school. It depends on you. Let's see if I can go back once. Well, one moment. I think it's a rule. There we go. Perfect. It's a rule that we have to have at least one technical difficulty when we're doing a Zoom presentation. I think we've had about 2 or 3. So sorry for that. It depends on you, and it depends on the teacher. So I would encourage you guys to have a good dialogue with any of your teachers, the ancillary staff, principals, and whatnot, just to make sure what they think is helpful. And as one more reminder, reminding to watch out for signs, learning issues, and similar with the Americans with Disability Act, the school is required to do an assessment for an individualized education plan and a 504 plan if indicated. Now we'll move on to what friends need to know. And this is, from childhood into adulthood. And this could be tricky because it's frustrating in terms of what do you want to tell your friends and what don't you want to. Again, speaking in very general terms, not all friends need to know everything. You don't need to give your entire seizure history from start to finish. But generally, close friends and their family members should probably knows some stuff, and this is mainly for safety reasons. So what do I do if you have a seizure? How do I manage it? But beyond that, it's really what helps you be more comfortable for being around them. A couple of tips going forward. I recommend having a rough script as to what to do if your seizures get brought up by either close friends, not so close friends, but still acquaintances, people around school that you don't necessarily know but are friendly, and if we're being honest, not so friendly people. So if there's bullying that's involved of all levels, having a general script of what to say, and it doesn't need to necessarily be a full speech that you have to give, but just some general talking points. It's a lot easier to have those things practiced before you are in that stressful situation, rather than when it's right off the bat and you're trying to make things up on the fly. And I would practice it. I would practice it while you're driving to work, while you're driving to school, if you're able to drive, while you're brushing your teeth in the morning. You can even talk to your dog and give these practicing. They don't know what you're saying, but they're really happy to hear it. This is mostly an excuse for me to show a picture of my own dog. But the other thing to keep in mind is that and this is speaking in general terms, but for most people and most teenagers, and as this is most the case with adolescents in most of your teenage life, is things are often much a bigger issue for you than for your friends, for you think you are. So I would be very surprised if your friends give your seizures even half as much thought as you give your seizures. And that's because your friends and your family know that you are a person with epilepsy. It's a part of you, and they see you as the whole picture, and you need to see yourself as that whole picture too. So that's just a last bit of tips in that case. I will pass it briefly back over to Dr. Sakura to talk about seizures and safety, and then we'll wrap it up.
Okay, so just briefly, so depending on the seizure type, seizures can pose safety threats. So again, most concerning are episodes where you lose tone, for example, you lose consciousness, awareness, etc. So always think about your environment, and this changes depending on where you are, what city you're in, etc., whether you're at home, work, school, and see whether or not there's safety hazards. So water safety, obviously you don't want to be swimming alone, showers, not baths if possible, careful around burning stoves, sorry, my child, and open fires, for example, safety from falls. So being careful not to trip on things, and being away from sharp surfaces, and then sleep safety as well. So trying to keep your bed safe as well. Next slide. Epilepsy and mental health. So, as we mentioned, epilepsy can coexist with other neurological psychiatric disorders, and 25 to 50% of individuals with epilepsy can also be diagnosed with a psychiatric disorder. So depression, anxiety, ADHD, for example. And so in adults, it would be most commonly depression, anxiety, and children, remembering that ADHD as well. Next slide. And so this may be due to changes in brain chemistry, also effects of anti-seizure medication, the effects also of the seizure, and difficulty adjusting to epilepsy diagnosis. So those with epilepsy are at higher risk of developing psychological disorders, and those with psychological disorders are also at higher risk of developing epilepsy. So it's a two-way street here. Sometimes a change in anti-seizure medication can improve symptoms significantly, but often, engaging and mental health specialists, for example, a psychiatrist or psychologist, can be very, very helpful. And some anti-seizure medications have indications for mood stabilization as well. And so again, this is sometimes, first of all, really important to be aware of when we're starting medications, and often trying to target two different things and potentially improve mental health symptoms as well, while also improving seizures with one medication. Next slide.
All right, I think this is my last one, and I don't think I need to take control over on this side because it's most of the background for this. It's important to know who has your back and who your support structure is. So this is both your personal support structure in terms of family, friends, if school, work, in terms of teachers, principals, etc. All of these people, they're in your corner, and knowing who specifically is really in your corner within each of these locations is really helpful. The other people who are in your corner are professionals, and this can be therapists and counselors. If you're struggling with all these things, we've mentioned anxiety, depression, ADHD, all of these things. If these are concerns for you, these are therapists and counselors are very helpful, and I would encourage you reaching out to them. And if there are people that, if you aren't following one and you're interested, your primary doctor will almost certainly have a large list of recommendations that they can set you up with. The other people who are in your corner is us. So we want to help. There's a lot of things that we can do. If you're struggling with side effects of medications, or if you're struggling with having problems remembering to take your medicines, if you're noticing that you're having some breakthrough seizures and you're embarrassed about talking about those because you're worried that there's going to be judgment, we can help with a lot of these things. But in order to help with them, we need to know that they're issues. So always encouraging to have a good dialogue and to work on talking things through with your seizure doctor. There's many really good resources that are available, that if you are interested in looking for it just in kind of general groups. Obviously, a great resource is the Epilepsy Foundation of Minnesota. The Epilepsy Foundation of America is another excellent resource. This is another plug, mostly for the kiddos out there. We have a summer camp from in mid-June of Camp Oz, that is specifically for kids that have had a history of epilepsy, or who currently have epilepsy. There's not just camp counselors and whatnot there. There's also health professionals. I'll be there as an example. So it's a good resource to also get connected with other people that also have epilepsy. So something else to consider. I think the next slide. And then the last one are some other more resources for social support. So EFMN, there's a lot of connect groups for adults, teens, young adults, parents, rare epilepsies. It's actually one of the first things I recommend if I am giving a new diagnosis of, say, a child who has Dravet. I had a patient who had a very rare gene mutation that there's only about 100 patients in the country that have this. And sure enough, there was a support group for that specific mutation that they can give resources for. So looking at that as a resource is really helpful. My Epilepsy Team is an online social network for those. And then also just Facebook groups, and then those all within that subcategory of social media. So Facebook groups, there's potentially people on it on Instagram. This is getting way outside of the millennial me in terms of knowing all the different social media resources, but I do know that they exist because my patients will tell me about them. So just knowing that these exist is the first step, but you got to reach out for them and interact with them for them to be able to be helpful. This last bit is just some citations, and then we'll move on to the Q&A section.
Okay, sorry, I was trying to unmute and it wasn't working.
No worries.
All right, so yeah, we have gotten a few questions in. I do want to encourage everyone who's listening to please continue to put questions into the Q&A box. We do have some time here, so we want to make sure you get your questions answered. So we actually have had a couple of questions on psychogenic events. One person was asking, and I'm kind of going to mix these two questions together because they're both about psychogenic seizures. So let's start out with the one that's just talk a little bit about what psychogenic seizures are, what the triggers might be, and then there were some questions about how to deal with it if you have one in public or while you're driving or any of that.
Well, and I'm you've talking to a good or a bad person, depending on who you want to talk to about this and how much time you have. Because I could definitely go on a very long tirade about psychogenic seizures, but we're already getting close to the 7:30 time, so I'll try to
Well,
keep it.
we're actually done at 7:45, so we
Oh,
have
okay.
time.
Well then, so I'm just going to give it. No, I'll try to keep it a little bit brief. So there's many different names for psychogenic seizures. They talk, I've heard dissociative seizures, psychogenic non-epileptic seizures. There's many different names for it. Um, uh, Non-epileptic seizures are probably the most commonly used term, and all it is a something that has all of the physical hallmarks of a seizure, but it's not due to electrical activity of the brain. So we'll hook a patient up for EEG. I do this many times, like for many different patients, that is, and they perform the event, and we don't see an EEG correlate. Now, that that does not mean that this event isn't real, that it doesn't mean that it's not concerning, and it doesn't mean that we don't take it seriously. It's just it's treated in a different way. These are manifestations often of anxiety, not necessarily things that people are doing deliberately, but things that are manifestations of stress. So we treat them by recognizing what the causes and what the triggers of those stressful situations are, and also by providing reassurance for when these events occur that you are in a safe environment and have the resources available. What we typically don't treat them with is rescue medicines. I don't recommend that my patients who have psychogenic seizures routinely go to the emergency room or they call 911 for these episodes, because that can often serve as a reinforcement. So it's a bit of a fine line, because I've heard a lot of very unfortunate stories from patients that have psychogenic seizures that have had a lot of rough interactions with other doctors because it's communicated ineffectively, and there's an element of judgment to it. But it is something that we take seriously. It's just treated in a very different way. I recommend pretty much every person that has one of these psychogenic seizures gets hooked up with a good therapist that they can have some regular interaction with, because they are the ones that do the lion's share of work, so to speak, in terms of treating them. Dr. Igler is the pediatric psychologist that I work very closely with, and she's absolutely essential in terms of these patients. Whereas I typically will still follow these patients periodically, because I'm not prescribing anti-seizure medicines for this. It's more of providing an additional level of support in this case. I think one of the other questions that they had talked about what happens when we talk about driving. So that it can be very tricky, because I was talking about, making sure we're reassuring and we don't take to the hospital, or we don't bring you to the emergency room. It is something that I do have to suggest that you don't, if you have, we treat them as seizures insofar as when we follow driving restrictions. Because whether or not this is related to epilepsy in the brain, epileptic activity in the brain, or if it's manifestations of anxiety, if you're not able to manipulate the wheel and react to stressors, you could be getting into an accident. So in the event that you do feel an event coming on driving, it would be the same reason if you have a focal onset seizure that has an aura. I would pull off to the side and wait for it to pass and call someone to try to get you into a safe environment. I wouldn't continue to drive and just kind of try to tough it out, if that makes sense. But when it comes to social or public places, this is the same thing about having an action plan. It's not necessarily when to give medications. Oftentimes I will have letters that are sent to my school, to patient schools, that say this is the event that that this individual is having. We need to be able to put them in a situation where they feel more comfortable, not necessarily taking them out of school, but if there's a room that's quiet and isolated that they want to just take some time to get back to their baseline and then return back to their classroom activities. These are the things that I typically recommend. Like I said, I could go on for ages with this, but I think that answers most of the questions that we had regarding psychogenic seizures. But we can open up to any others that are coming along.
Yeah. Dr. Sakara, did you have anything you wanted to add to that at all?
No, I think Dr. Mendez was very comprehensive, and,
Okay.
and I have a very similar approach.
Great. The next question was about how common it is to have more than one type of seizure.
So I can go ahead and start. So with respect to, some people have both epileptic and non-epileptic events. So sort of just tying in with that previous theme. And again, it's really important to talk about, some questions I just start with is how many different types of events do you have? And then we go through each one in detail. And some of them sound very suspicious for epileptic seizures. So, transient, start, stop, stereotype, meaning each one is very similar or the same episodes. And then sometimes there can be features, based on duration or, it's hard to localize it in the brain, the particular actions during a seizure. And so sometimes you start thinking, okay, this might be epileptic, it might be non-epileptic, and I think it's really important to remain humble. And again, what Dr. Mendez said, the gold standard is getting a really detailed history and then getting that EEG data to monitor and capture events during the seizure to clarify whether or not there's abnormal electrical activity during that. So I think about 10 to 20% can have both epileptic and non-epileptic events. And then in terms of individuals having epileptic seizures, there can be different seizure types depending on the epilepsy syndrome and the cause. Sometimes there's seizure type, there's different severities and durations and intensities. So a seizure can start out very similarly, that aura and the part that you remember is very familiar, and then you might lose awareness, for example, or you might lose awareness and then go on to have a generalized convulsive seizure. So it might all start as the same seizure and then become more severe, or you might have different areas of the brain that are affected and have different seizure types. And then some epilepsy syndromes are known to have several different seizure types. So again, I think that it is definitely possible, and talking about each type of episode that one is experiencing individually. So talking about each one is really important.
Yep, that's pretty much all the things that I was going to touch on as well. It's, if you think about it as your brain as real estate, right? So different parts of your brain focus on different things. So if you have, the occipital part of your brain has to do with processing images. So those can relate to seizures, can cause visual phenomenon. But if it spreads and involves the brain as a whole, that can sometimes be viewed as a different kind of seizure. Now, whether that's coming from a different part of the brain or if it's spreading from one region to another is a different question, and we're kind of digging into a kind of a deeper well than we probably have time for. But the short answer is, it is not, strictly speaking, common to have multiple seizure types, but it is certainly something that I encounter regularly.
Okay, thank you. We have a question asking, is it best practice, or when should you go to the ER and have a CT when having a seizure that causes a fall and a significant bump to the head? But if there's no cuts or bleeding. But so you have a seizure, you fall, is it important to go to the ER? Should you ask for a CT?
This might be a different question from the adult versus pediatric side. So I'll start, I'll let Dr. Sakira start first if she has anything to add, just because I have munchkins in various different sizes. So I'll let Dr. Sakira start with that.
Honestly, I think everyone is very, very different. I think it's really hard to say this is the exact reason. I think if in doubt, it's never going to be, harmful to be assessed by either the ambulance or a medical professional in the emergency room. And so I think, definitely if there's any question, it's always best to do that, because, I think it's really important to be proactive about it, because you can't go back 10 hours later and say, oh, I should have been, evaluated. And so I think everyone is very different. I don't have a one size fits all approach. If in all of my patients, I say, if there's injury during a seizure, if there's concern for injury, then you should seek medical attention.
Yeah, okay, but might turn out not to be all that different from the adult and pediatric side of things, because my recommendations is often the same. There's obviously a difference between if, I have one of my, toddlers who's having a drop seizure and they fall down from a height to the ground from a height of 1 foot, and it bonks their head and they cry. That might not be the same as if someone who is standing at full is wakes up after a seizure and notices that they have a big old goose egg on their head and there's blood on the ground. These are big differences, and we also we're speaking as to in general terms rather than in specific situations. And in this purview that we are at this group forum, it really is in our best interest to err on the side of caution. And I never discourage any of my patients or their families that if there's a concern that you should go to the emergency room, I never want to discourage you from doing so, because that's what they're there for.
We have another question going back to psychogenic events and wondering how long they generally last. Is that a pretty individual thing?
Again, I'm speaking with broad strokes. That it is generally speaking, if you have an event that is very, very long, as in 30, 40, 50 minutes long, and following that event, there's a prompt return back to baseline, that errs on the side of psychogenic rather than epileptic related seizures. There's all different kinds. The analogy I use for psychogenic is it's kind of like a panic attack. Different people react in different ways. You can have people who have a panic attack and they're just kind of saying they're acting, their usual self. Sometimes they stare off into the distance. Sometimes they hyperventilate. There's a lot of different versions. So it's hard to speak in general terms, but they can range in many different ranges. But one of the things that raises my suspicion for psychogenic events is if they're very long and then all of a sudden come back to baseline. But when we talk into each of the individual minutiae between those, kind of a long story.
Yeah, and I think just to sort of piggyback off that, most epileptic seizures are short and they're self-contained, because after that abnormal excitation of the brain occurs, which is what happens during the epileptic seizure, the inhibitory network of the brain shuts it down. So most epileptic seizures last between 30 seconds and 2 minutes or something like that. Again, we take everything into consideration, but when seizures are much more prolonged, it raises suspicion and concern. And again, there's workup that needs to ensue.
Okay, great, thank you. We have one here. I'm not sure exactly what the question is behind this, but it's talking about taking Keppra and now having insomnia, anxiety, depression, and this individual's working with a sleep doctor. So I'm not sure if it's a reference to possible side effects or comorbidities, but I don't know if either of you can address anything about whether these types of, I know we talked a little bit during the presentation itself about some of the comorbidities that can happen, some of the mental health issues that can occur. But what struck me about this one is that they're now working with another doctor on just sleep issues. So maybe addressing a little bit about that and other doctors that may get involved in the care of a person with epilepsy.
Yeah.
I can.
Oh, go ahead.
I knew that was going to happen. Yes. So I'll talk briefly on it. You were running the medication side of things, so I won't speak too long about it. But this is not an uncommon problem that we're confronted with. Is you have a patient that may or may not have anxiety, depression symptoms before an event before seizures happen, and then we start on medicines, and then these symptoms persist, or they get worse. Now, is that related to the medications, or is it part of the baseline? And often that is very difficult to determine. If we have a suspicion that the medicine can be having a detrimental effect, we certainly have other options to consider, but that also follows with it a balancing act. That is, how do we balance seizure control with the side effects of the medicine? Touching on with the sleep medicine doctor, we often will get sleep specialists involved if that is a contributing factor, especially if there's nighttime related events that we're trying to delineate as seizure versus sleep related events. Sleep medicine has been really helpful in that, and more, this is one of those situations where more cooks in the kitchen is actually a good idea. So
Dr. Sakara, did you have something to add?
No, I mean, again, this is an example of, common side effects can be occurring, and it's about taking the big picture into consideration and having that discussion with your healthcare provider. This is what I'm experiencing. I want you to be aware. This is how it's affecting my daily functioning. What are your recommendations at this point? Definitely going back to that comorbidity thing. I'm always talking about sleep because, as we mentioned, it's a very common risk factor for having seizure, poor quality of sleep, poor duration of sleep. So we're always talking about the comorbidities, depression, anxiety, cognitive deficit. So engaging with a sleep specialist is something that I often do with my patients.
Okay, great. We did have someone who just made a comment that might be helpful for others, and I think this may be going back to the idea of if you fall during a seizure and do you need to go to the ER or not. And this individual said that the health insurance has a nurse line that can be a useful tool in just calling to determine whether they need to be seen at an emergency room, at urgent care, or just follow up with a regular care provider. So not really any different than what would happen with an individual without epilepsy, but it is a nice tool that I thought I would share since this person shared it with us. I got a question.
That's a great. I'll just echo on that as well, because that's a very good question. If you're I have patients that, as an example, they live in a really remote area, right? So they have, and the nearest, and especially if they have if they have a complicated seizure diagnosis, sometimes it's hard for a smaller location to have direct experience with it. And sometimes you just have another question and you don't want to necessarily have to schlep and drive 30 minutes to go to the emergency room to get an answer. There's a reason why doctors are on call, right? And every essentially every hot clinic and doctor that you follow with has an after hours number. Now, whether or not that goes specifically to a doctor or an additional line may be seen, but it's someone that you always have the ability to talk to. So if going back to that question about falling and hitting your head, if you have other questions, they're the person to ask to. So, but Debbie, you had another question?
Yeah, I actually was contacted by someone this afternoon who wasn't sure if they were going to be able to make it tonight, so I'm not sure if they're on now, but I'm going to go ahead and talk, ask about what he was concerned about, is that he's been given multiple names for some of for what he's experiencing, and I think I hear this a lot when I talk to people who call the Epilepsy Foundation, that there's some confusion about what the different seizure types are. You've got complex partial seizures, partial symptomatic. They've talked about localization with this individual. And so it's like, are those all the same thing? I know that the names of seizures have changed over the years. So maybe if you can just address a little bit about that, it would be helpful. About what
I can kind of just go ahead and start. So I think the first comment I want to make is that it's really important to describe what happens during the seizures, because sometimes there has been a misdiagnosis somewhere, and so it's really important when you're meeting a new doctor, establishing care, following up, to make sure you're describing what happens during the seizure. And so from the very beginning to the end, and offering any additional information in terms of collateral information, videos that might be available, etc. So that's the first step, which is really, really key. And then I do want to just quickly, this is a little bit of a side note, I want to just mention that often the first seizure that presents to medical attention is a generalized convulsive seizure. And sometimes there's been small, more subtle seizures before that have occurred and that have never been picked up, not through, the first lines of defense. Again, Dr. Mendez and I went through specific epilepsy training to learn about all these types of seizures. And so it's out of the scope for, some other more general healthcare providers. So it's really important that you're feeling comfortable and that you're talking about all the different potential seizures, maybe a strange, funny feeling that you get too, because it's been, noted in the literature that the most commonly reported events that lead to medical attention is motor seizures or generalized convulsive seizures. So that's sort of my little side note. But in terms of the epilepsy classification, so the International League Against Epilepsy, the ILAE, updated the epilepsy classification recently. So it's always evolving, and there's a bunch of, there are several epileptologists that get together and try and come up with classifications, and it's evolved over time. So what was once a petit mal, also a focal, a simple partial seizure, now is divided into focal aware, focal unaware seizures. So everything, is very, very, it's always changing. And I think that's why it's just really important to explain what happens during the seizure and kind of make sure that you're understanding the general sense of it so that you're empowered and you can actually sort of say, I was diagnosed with petit mal, but that's not actually, or, that you're familiar with the information. But I think, again, the broad types of seizures is the focal onset seizure or the generalized onset seizure, and then whether there's motor involvement or not. And then there's several different variations based on that. But again, the localization related is a focal seizure starting in one area of the brain. So very confusing, completely, understand. And I think just having that conversation about what exactly is the type of epilepsy I have and why is that, how did you get to that diagnosis? Those are really important conversations to have.
Yeah, and that's certainly not the first time I've heard that question, and that's just something that we, the ILAE did a great job of changing these classifications to make them a little bit more intuitive, but it doesn't change to the fact that a lot of people have been using the older nomenclature for a very long time. So typically when you think of complex partial, this is focal onset, and petite mal is in a similar way as opposed to grand mal. That's usually the description that was used for a generalized tonic-clonic seizures. And talking about what episodes are witnessed, the one that brings the attention of are the full body seizures. A good example of that being kind of potentially a red herring as a generalized seizure are ones that happen out of sleep. So most of the time people aren't witnessing the onset of a seizure, especially if they're happening in the middle of the night. And sometimes you'll have a seizure that starts focally and then spreads, and that's when people notice it. So, and what it really comes down to is just describe the event. And that's a really good point that Dr. Sakira put up is because regardless of what vernacular you're using, you describe what's going on, and we'll be able to, we can translate into medical jargon and from what we're describing. And insofar as when I get calls from outside hospitals, if I hear, oh, it was a generalized seizure, I always have to double check that because I've heard every single type of seizure described as a generalized seizure. So I'm used to just hearing what it sounds like and translating it in. And if you have questions about it, this is other things just to bring up with your doctor so that they can clarify.
Right. Great advice. Thank you. We are out of time, and I apologize. I should have cut the questions off a little sooner. I didn't quite realize how late we were running. So I do want to thank both Dr. Sakira and Dr. Mendez for being here. It's been great information. I really appreciate your expertise. Want to just remind everyone who the Epilepsy Foundation is. We lead the fight to overcome the challenges of living with epilepsy, accelerates therapies to stop seizures, find cures, and save lives. I want to put a quick plug in for our information services program. We offer free one-on-one support for individuals and families living with epilepsy, as well as for those who work with people with epilepsy. So if you have any questions at all related to epilepsy, please reach out to us. You can do that through our website. And if we don't know the answers, we will do our best to find them for you. And I want to let everyone know that our next Wellness Wednesday webinar will be held on April 27th, and it will be on the topic of Social Security disability, something we get a lot of calls about. So again, thank you all for attending. Thank you again, Dr. Sequeira and Dr. Mendez, for lending us your expertise. And I'd like to just wish everyone a good evening.
And thank you very much for having us. We really appreciate it. And thank you for joining us this evening. Take care, everyone.
Good
Have a
night.
good night, guys.